You are listening to the Medical Education Network.
Welcome to Health Chat, the weekly podcast from the Medical Education Network, where we explore the people, technologies, and innovations shaping the future of healthcare across Africa. I'm Linda Ravenhill, and this week, as part of our Code to Care series, we're asking a big question. Can AI help close the healthcare gap in Africa? And if so, how? So, to help us unpack this and provide us with some real world experience, I'm joined by someone who's been at the forefront of tech driven healthcare transformation on the continent for some time now, Dr. Ernest Darkoh, co founder of Vantage Health Technologies and longtime champion of digital innovation in public health. So, from HIV, TB to cancer and COVID, Ernest and his team have been leveraging AI not just to treat illness, but to build smarter, more sustainable healthcare systems that use scarce resources more effectively. Ernest, it's a real pleasure to have you on the show. Welcome to Health Chat.
Thank you for having me.
We're really excited for this conversation. So, what we do each week in this series, Ernest, is just go back to the beginning and introduce you to our audience. So you've been a powerful voice at the intersection of public health and technology. Could you tell our listeners a little bit about your journey and how you ended up in tech, and then what led you to co-found Vantage Health?
Thank you. It's actually kind of ironic because I literally know very little about technology. I'm not a technologist. I'm a doctor with a public health degree and an MBA. But I think I've always had an insatiable, curiosity about of how things actually work. And I'm always, even as a child, I'd take apart my toys. I'd be more interested in taking apart my toys to see how they worked rather than playing with them. And I do the same now with health systems and try to figure out why is it broken, why are things not working, and then how do you basically fix them, and how do you put them back together. So I grew up into the person basically who does that at a systemic level. So I refer to myself as a doctor of systems more so than a doctor of patients now, but those systems are required to treat the millions of patients. So so I ended up in tech, basically out of necessity. We, as our company has been implementing large scale healthcare programs on the African continent for over 22 years. And doing this mostly again through old school approaches of, you engage with a province, a district, or a country. They tell you the problems. You go out and spend months on the ground doing diagnostic work, gathering data to understand, what's going on, then coming back, implementing solution, developing the solutions first, and then trying to implement those solutions. And so we've done this for, like I said, over 22 years. But going a little bit backwards to when we actually started using technology, this was around circa 2012, 2013, when in South Africa alone, we were responsible for about 20% of the country in terms of being a support partner to the government to implement the HIV, TB, and PMDT programs. And we realized that, just for example, we were responsible for over 1,100 health facilities, and to just do a root cause analysis of what's wrong where, so that you can adequately, allocate your resources and your solutions accordingly, was taking us most of the year. And you remember, you have to spend your budget in that year, right? And otherwise you lose the money. So we realized this is just not on. And in essence, trying to run large scale health systems based on paper and Excel was just, you had reached the limit of that, with the result that you are always flying blind, making decisions without the benefit of any data, therefore not allocating resources effectively, but most importantly, not even spending the money you have, and often having to send it back. So that's when we realized it was the early emergence of the cloud. There was a big talk of big data then. And at the time, they called it machine learning, not so much AI. But in essence, it's a part of the AI family. We saw a big opportunity in 2012 as this came about, saying this could really transform how we do public health, moving from this sort of manual, old school way of trying to manage, to a new age way of managing that was much more proactive, much more responsive to what was going on the ground, but most importantly, in essence, technology could be a silver bullet that solved a number of critical challenges that were responsible for why nothing works and why we have bad health outcomes. Could we use technology to, in essence, hack this and bridge the skills gap, right? So if I was a doctor on a Friday, I've been appointed into a management role, the technology can support me to make the right decisions, to ask the right questions and to make the right decisions and to take the right actions, right? The next
Mm-hmm.
action that you take. And we found, and for having done this manually, we knew the archetype of what a minister needs. We knew the archetype of a provincial manager, a district manager, a hospital superintendent, a nurse in charge of a clinic, and the ways in which technology could really augment what they're doing so that in their roles, they all do better. And by doing better, they improve health services. By improving health services, they improve health outcomes at scale. So we were able to therefore figure out, look, if we're going to use, the machine and use data intelligence, how to basically thread the needle such that we can solve all these problems in one sort of one elegant platform solution. So that is really what Vantage is.
Okay, so there's a lot to unpack there. So, but I think to start off this discussion, I think maybe let's just maybe shoot ahead and then we can work our way backwards. So given what you know now and what Vantage is capable of and your experience on the continent, what do you think an AI-powered healthcare landscape looks like in Africa, would look like in Africa from where you sit? And I'm very interested in knowing from your perspective what you've seen that's working well, and if you've got any examples for us, and where you've seen the most exciting shifts on the ground when using the technology.
Yeah, so for us, an AI-powered landscape is really what we, in Vantage Health Technologies refer to as delivering on the future of healthcare, the future of work in healthcare. And that really is moving AI, helping us move from what is typically a very late and reactive way of delivering healthcare and health services to one that's much more on time or real time and proactive, right? So meaning you are either identifying things before they go wrong and being able and then addressing them, or identifying them early so that you can address them at a time where it's much more cost effective and frankly you have better patient outcomes than when people are in deep crisis and needing what I call heroic measures to save them. So we see AI in essence supporting the health system to be better holistically in so many different ways. And it can do that by providing the intelligence that is required at every level, that ensures, for example, that you are first and foremost, you know what's going on in terms of your country. Where is the disease occurring, right? Where are mothers dying in childbirth? Are we getting the most HIV infections? Where do we have our diabetics? Where do we have most injuries, et cetera, right? And therefore being able to ensure that then the services are being matched commensurately to where those things are happening the most, right? So I call it being able to focusing for impact in essence. So if you have in the background AI going through all the data and always surfacing for you, these are basically the areas you need to focus on and pay the most attention to, because this is where we're having the worst, in essence, health impacts. That, by the way, saves you spending effort and time on places that you don't need to be spending time on. Now, without data, the current standard of practice in terms of management is I try to apply my butter on the bread evenly. So, for example, if I hire 400 nurses this year, I try to give all my 400 clinics one nurse, right? But in reality, one clinic needs 10, another clinic is overstaffed and doesn't need that one nurse. But without me knowing that, I again apply everything evenly and I don't have impact. I wonder why I'm not having an impact against what I'm trying to address. But with intelligence that is always pointing me to this is actually where you need to apply the ointment the most, right? And by the way, timely intelligence. So I'm not talking about the current standard where most people are looking at quarterly reports, meaning 3-month-old data or 6-month-old data, but me responding to what's happening ideally today, or fall back what happened yesterday, and then maybe fall back again to maybe what happened last week. but we cannot be trying to drive forward by looking in the rearview mirror of what happened 3 months ago, right? So AI can really transform the way, in essence, the optics we have of what's going on, allowing us therefore to make much better decisions about how to allocate our resources. And I'll give you, for example, an example of why this is very powerful. In Ugu district, we had been asked to assist them because they were ground zero for the HIV epidemic here in South Africa. And when they have roughly 75 clinics, and when we initially engaged with them, the district manager, in essence, expressed, look, my district is just broken, right? I have, the highest prevalence. There's, my numbers per the UNAIDS targets of 95 are terrible. In fact, at that time, their third 90 viral load suppression was 32%, which was, really one of the worst in the country. Yeah. And they're like, I can't fix this unless I get hundreds of more nurses or thousands of nurses hired and hundreds of doctors hired, this many more community health workers. There's nothing I can do about this situation. And on the surface of it, yes, you can understand that because it just looked so daunting what they needed to accomplish. So we brought in our Vantage technology solution. And one of the things Vantage does is we overlay it on all of your current data systems, and it begins to answer certain questions for you, like which of your facilities are causing our biggest gap to target, right? And so when we applied this sort of algorithmic thinking to the KZN data, it revealed that something like 8 of those 75 clinics were causing 80% of the problem.
Gosh.
So like, okay, so it's not a 75 clinic problem. You don't need to fix 75 clinic to address, for example, your viral load. If you fix these 8 alone, you address 80% of your gap, right? So what we did is we hyper-targeted all of our efforts, all of the resources on those 8 clinics. Now, remember, you don't have the budget to fix 75 clinics, but you have the budget to fix 8 clinics, right? In fact, you have more than you need to fix 8 clinics. So by focusing on 8 clinics, we moved their third 90 from 32% to over 90% in less than 6 months.
Wow.
Right? By the way, Ugu district became the first district in South Africa to hit the triple 95 target, the triple 90 targets. Right?
So that was going to be my question.
At the time, that was in 2019, right?
Okay.
So that was 4 years ahead of the next district to hit triple 90, right? So this is the power of using machine learning, AI, data analytics, intelligence, and this this is a very simple use case I'm giving you, right? Which is to be able to actually deliver disproportionately high results for the really scarce resources you have, to the point where it literally becomes a national leading program. And this is just one simple use case. A more complex use case, which we've also implemented in a number of countries, is where when you talk about one of the biggest issues, for example, for your second 90 in HIV, is people dropping out of care, right? You're trying to fill your basket with people, but you have a leaky basket. I put them in, but I lose a lot of them. At one point in South Africa, I think we're losing like 40% of patients enrolled at the 6-month mark, right? So you can imagine also the kind of billions of rand that are being wasted in that scenario. So what we said is, instead of the standard model where we look at who got lost and then try to find them, meaning hiring community workers and other community caterers to go and search for them and find them, which is very costly, we said, can we actually prevent that loss from happening in the first place? So we started to apply predictive analytics on the patient data, right? And we trained the model, and the model became about 90% accurate in predicting who of your current patients is about to drop out of care. And then what it would do is weekly it would generate that list. You would reach out to those people and then intervene with them more intensely. And for example, in Nigeria, in the IHVN program, we saw something like 90% retention in the group where we applied the predictive analytics compared to 55% retention, right? which is a game changer. I mean, I can't even, when you
Yeah.
add the benefits economics and all around health economics around that model, it's a game changer. And so these are some of the ways, again, when I talk about this can be done. It can be done very practically. It can be done very successfully. It's been done. It's not theoretical. But,
Yeah.
but most importantly, believe it or not, we're doing this despite the fact that those facilities still operate on paper. Does that make sense? Right.
So
So
yes,
we didn't
absolutely.
have to we didn't have to digitize or have electronic medical records to have this kind of benefit even today. So a lot of I think there's a lot of sense that everything needs to be digitized first before you can derive the benefits from AI. My point is this: you can the best benefits you can derive from AI are by you not having to do much yourself in terms of data capture, data inputs, etc. If the AI can analyze it and give you what you need, that's you just need what you need. You don't need to all the work of having to gather the data yourself, etc. If the system can basically feed you what you need to take the next best action, and that then delivers the kind of results that I've been alluding to.
Okay, well, that was going to be one of my questions. So I'd like to explore that a little bit more, but I think maybe now's a good time to just chat about the data.
Yes,
Um, and specifically, obviously, it's info out, I mean, info in, info out. But
yes,
one of the biggest challenges in Africa, and definitely in South Africa, is the lack of a unified EMS system.
yes,
Now, I know there are a lot of measures in place to address that, but it's going to be some
yes,
time before it happens, and how it happens
yes,
is anybody's guess. But in the absence of those fully integrated systems, you're so heavily reliant on that data. How do we navigate that gap? How are you? Is it this paper-based system that you're making use of that rather than relying on
yes,
an EMS record? But obviously that's restrictive because you
yes,
really want to get this comprehensive picture to be fully effective. So, like,
yes.
how are you guys addressing that? And how do you think the continent, well, let's just talk about South Africa for the moment. How could South Africa address that in the interim so that we get meaningful insights on a much larger scale?
Yeah, so I think exactly. Obviously, an EMR or electronic medical records, that would be a gold standard. That it would be a nice to have. And I know there's efforts in South Africa and various African countries to implement various electronic medical record solutions. That said, implementing those solutions is a lot harder than people think,
Mm,
right? And I think this is why we're not seeing many of them successfully implemented or scaled on the continent to date. There's a lot of underestimation of what it takes because it's not about the technology, right? It really is not about the technology per se, because most of the technologies as they stand would work. You can go and buy an off the shelf or relatively off the shelf EMR. You could find a country that has one. You say, I like that. I can bring it. As a technology, these things, you'll probably find ones that all of them work in essence, right? What typically fails is the human process and discipline underpinning then what would have to be in place and able to enable that technology to actually uh, land and thrive, so to speak. So for example, um, at the moment, we are not doing international classification of disease coding, ICD-10 coding,
yeah.
right? You don't have ICD-10 coding. So let's say, and by the way, so that's just a completely new concept. Nobody knows it. Most people may not even be aware of the terminology, right? So let's just say I go and capture all this data, but there's no ICD-10 coding into an
Mm,
electronic format. How useful is that?
not at all.
Right? Hardly useful, right?
Mm,
So my point is ICD-10 coding, you don't necessarily need an electronic system to be operating in that mode, right? So what I always say, technology is just an enabler, right? It should be enabling an already effective solution or an effective process that you have in place, and should be enabling effective behaviors, institutional behaviors that you have in place. It doesn't necessarily create those behaviors on its own. In fact, often if you come in and digitally enable the current situations as they are, you're just putting those current bad situations on steroids, right? So what I found is there's an underestimation. They think it's about the technology, and if somebody comes in and just plops this technology here, it works. Not understanding you have to put in the data. You have to have a discipline about capturing it. You have a discipline about how you use it. You have to have a discipline about how you maintain it. And then with EMRs, I think one of the biggest, I say, faux pas I've seen so far in my experience, and watching countries over the last 25 years grapple with this, is that there's this thought that if I come in to a clinic today, and let's say you've implemented an EMR solution, and then you capture my encounter today into that system, there's a belief that now that's an electronic medical record. It is electronically captured data of one interaction. And EMR means I have to go back and back capture all of your interactions in the health system, wherever it's been, public, private, etc., in South Africa, from when essentially you were born. Then it becomes your full electronic medical record. And when I talk about the data therefore being deep and useful, and I can analyze and I can follow trends and I can predict on you based on your data, I need all your longitudinal data in there to do that at a patient level. So I'm not saying you shouldn't do it. What I'm saying is it takes time, right? So America was going paperless when I was in medical school, working in the Harvard hospitals. I vividly remember, literally, we were told from next week we shall not use paper. They removed all the paper from the hospital. Most of us didn't know how to type. It was horrific, But that was 30 years ago when they went fully paperless, non-digital. So they've had a learning curve, right? And a maturation over time. Me just knowing what happened in your last 3 visits, it's nice administratively. Yes, it helped me maybe find you quicker when you come to the clinic, but it isn't constitute, quote unquote, an electronic medical record. So that is, yes, it needs to come along. By the way, if we have electronic medical records systems like Vantage, it would be like giving them jet fuel, right? Because we could do so much more now with
Sure.
AI sitting on top of good electronic data. But without it, what's the next best thing? The next best thing is I can use the aggregate data that we have. I can figure out creative ways of getting it from the paper quickly into our system through various ways of ingestion, optical character recognition or whatever, and use it, but meeting people where they are, if that makes sense, right?
Sure.
I can begin to really unlock the value that's sitting in all of these different data systems, which we spent billions on. So remember, you have lab systems, HR systems, finance systems, procurement systems. There's data all over the place, not to mention social determinants of health data and weather data, all these things that are out there. But right now, to date, there's nothing that brings these all together and allows you to very quickly get on top of them, identify patterns, analyze, pull out intelligence.
No, that makes sense. So, Ernest, just from a technical perspective, from a jargon perspective, the optical character recognition that you're talking about,
Yes.
how does that work? Just for our practitioners, how does that work in translating a paper-based system to a more electronic system?
So, for example, right now, just in very simple terms, let's say you have a page of text, right? Optical character recognition if it looks at that page of text, it can actually tell you what's on that page. It can translate what from that visual. Let's say it's a medicine bottle, right? Optical character recognition can read what's on the bottle, for example, for you, right? So meaning I don't have to have a data clerk sit there, capture from this paper, really copy it out again into electronic format for me. So it becomes a much more rapid way to ingest, in essence, data that was what we call unstructured data. So meaning this could have been in a PDF. It's not in machine format that's
Right.
easy to grab onto. This can take something from a flat format like a newspaper and pull it into electronic format and still keep it logically sensible in terms of then it being ingested into electronic format. Does
So
that make
that's,
sense?
yeah, so that would be a bit of a silver bullet, I would imagine, in certain practices where there are just paper-based records. Is that how you do it? Is that how
Well,
that?
so yeah, so we're not really doing that at this particular point because,
Okay.
as I said, to go and digitize all this stuff in order to then make it then useful, I don't believe we have the time for that.
Okay.
right? So we're skipping that step. We're not focusing on trying to fix all the underlying data. We're saying you can use it as it is,
Okay.
right? So meaning if I need to grab that piece of data from this one source and this other piece of data from this source and this other piece of data from a third source in order to answer a particular question, all I need is those pieces of data. I don't need the whole data, each of those data sources to be electronic. I just need to be able to gather that one piece of information, and then algorithmically combine them to give me what I need. So we found a much more powerful way of getting at data quality is actually using the data. Because only when you start to use the data does it unearth that the quality is really bad. And by the way, the quality was bad because people were not using it. So I always give this example. If I'm a
That's a very interesting take on it.
exactly,
Actually, never thought of it like that.
yeah. So if I give an example, remember the average district manager, provincial manager, national manager is receiving hundreds of reports a month, hundreds of reports being emailed in, sent in, paper delivered, hundreds. And there's so much that all they can say is noted, thank you, I got the report. But they don't have the time to read these things, right? So if I was one of the people inputting into that report, let's say I'm a district manager in X, I send in my report, but I'm sending in that report based on only 30% of my clinics, for example, having reported. It never gets picked up, right?
Mm.
Because no one's asking questions. No one ever asks any questions of the data. So I can keep doing that. I can keep having incomplete data submitted. But the day I send it in, and then the system tells me, oh, Ernest, you are the worst performing district in measles immunization. And because the AI has analyzed me compared and all the other clinics and telling me I'm the worst, I'm like, wait a minute, what's going on? Why am I the
Yeah.
worst? And it's transparent now because and so now I'll be like, wait, oh, I only submitted 30% of my facilities. Let me make sure I get the other 30 to submit. The rest, the other 70% of my facilities to submit. So this is the kind of when you start to ask questions of the data, it leads to people investing in fixing the quality, but not the other way around.
I want to pick up on something you've just said about transparency. So it's a slightly different take on it, but one of the ethical flashpoints on the use of AI is around transparency and
Yes, yes,
bias in
yes,
that. So taking Vantage, maybe putting it to the side because I think you're obviously training your models directly, but in Africa, we do have this problem that most of the AI systems are trained on data, perhaps, that doesn't reflect our diversity. So I'm interested to know your opinion about the risks when when the data that's used to train these systems doesn't reflect that. And if algorithms are guiding care decisions around that, I guess the question is who's guiding the algorithm? How do we build trust and transparency into these systems?
yeah.
Um,
Yeah, so a couple of things. So I'll talk first generally about the issue of bias, right? And I think often I found when people ask that question, it's implicitly. I think they're referring to the fact that these AI models, let's say it was built based on people, let's say training on a European data set, right?
sure.
But then I'm trying to apply it in Africa. In which case, yes, of course, yeah, like if I always say AI is just a reflection of us as we are, right? You know what I mean? Like
Yeah.
if I never, for example, interact with white people, and then I train AI, my AI will end up with my view of white people, right? So I think implicit to me behind that question is almost like, therefore, which data sets were used in training your models in terms of an underlying. And I'm talking about in general, not just healthcare. So to me, we're building AI in Africa. We're using the populations that are in the places where we live in Africa.
Mm.
We're training on this data, right? So ironically, our AIs may have an African bias, right, in terms of the African context and African situation, right? So if I was taking and trying to lift and shift my AI to now apply it to a white Midwest population in the middle of America, it would have a problem the other way. What I'm saying is, I think often people almost imply that almost like the AI itself is coming up with the bias. often it's just reflecting the biases we have. Therefore, to come back to your question, it's being conscious about what you're training it for and in what context you're training it for. And related to then, when you say AI now being applied to patient care, I think there's very, very many steps before we get to the point where, for example, AI is the one autonomously making a diagnosis, right? And determining the course of action for a clinical intervention for a patient. I think we're a ways from that, right? I think we're still very much in the zone where AI will act as an assistant to the doctor or a co-pilot with the doctor or with a professional. In essence, it's helping them to back up their decisions. It's helping them to cross-check their decisions. It's helping them to say, hey, did you think of this as well, right? Because I went and read every article on cancer in the last 2 seconds, and I know you as the human doctor has said, I think this is what it is, but I've just gone and read all the articles. And have you thought about these additional things? So we've not taken the human out of the loop. The way you keep it safe, and the way you keep things safe is you give it guideposts, right? You create guideposts that, for example, if it's going to make a recommendation for an action to be taken, it can only make the recommendations from this particular data set or this particular data pool. So to make it practical, let's take South Africa, let's take HIV, for lack of a better disease, right? HIV has certain guidelines in South Africa, right? So if I tell the AI, you're going to look at patient data, you're going to analyze, you're going to make recommendations, you can bound it to say you will only look within the South African guidelines and make recommendations within that. And if it's not in there, your answer will be like, I do not know. Please refer to somebody else for this. I am not programmed to answer that question. So, and the way, for example, we have been programming AI is when it supports a decision of a human, we also make the AI put its justification right next to it. The decision the AI, for example, is recommending. So the AI recommends this, and it says, this is why I'm recommending it.
Okay, but that goes back to transparency.
Exactly.
That was the earlier question. So you know how these decisions are being made. And I think
you know how it derived, which data it pulled on, and you'd be like, no, that's a debunked study that it pulls from, right? But in the early days, in particular now, we need many, many of these guideposts. And also, I for one, for example, this is why we do not use AI in that, except for the predictive analytics part of it with patients, we mostly have stuck with the systems use cases where you're using it to improve your management decisions, your resource allocation.
Okay, Ernest, if I was to tell you that we're almost time's up, would you believe me?
Of course.
So we're going to have to have you.
What happens to that? Like, time just contracts in these interviews.
It does, for sure it does. I was going to say I have 5 more pages of questions, but right now I only have time for 2 more.
Please go for it.
I'm trying to
I'll
choose.
I'll try and be brief.
So I guess of my 5 pages, my last 2 questions to you would be, what's the big unlock? What do you think needs to happen in Africa from your viewpoint to enable the kind of large scale adoption that we need to really make a difference at these primary care, community healthcare level? But I think just in general, what do you think would drive that sort of mass scale adoption? Do you think it's one thing, or do you think it's going to be an iterative, more longer term process?
Well, if you talk about what's needed right now, we are heading towards a very long-term process. The way that the African continent, and I know I'm overly generalizing that, there's countries like Rwanda that are way ahead.
Sure.
Kenya, I think, is rapidly catching up. But in general, and I know I'm overly generalizing, we are just moving too slowly on the fourth industrial revolution, and just grabbing this by the horns and using it as a tool to really elevate the continent to catch up with the rest of the world, if not to be at par with the rest of the world. I mean, I think, we missed the first, second, and third industrial revolutions. We can't afford to miss the fourth, and we're kind of right now at the back of the pack again. So we are in Africa again. We're still approaching AI in a very fragmented, disconnected way, right? Where we're seeing it as pilots. I'll do a pilot here, a pilot there. We're not seeing AI as actually this is the future to our future um, economic health and social prosperity, right?
Yeah.
We're not seeing, for example, AI as the way we're going to tackle unemployment in our countries, right? This is what's going to drive our national productivity at some point and see it as a point of national competitiveness. So it's not about, a little pilot here and maybe this doctor there might use it. It is about really, reforming our economies and our overall approach as countries to say this is the way forward. And so, to give you an example, I was a vice chancellor of one of the universities here said they had gone and done some benchmarking in America, and of the first year entry class at a top American university, of the first year entry class, 85% or something of all of the students had technology in either as a major or a minor in their degree. 85%, right? Um, if I ask you that same question in Africa, right? You know
Yeah.
what I'm saying? And by the way,
Yeah.
and they've been doing this now for decades. So how are we going to catch up? How do we catch it? So it's not about just saying there's a technology there, because if it is, that means we're just again being a consumer of other stuff people have built.
Exactly.
So if we are going to really get on top of this, we need to get serious about it. And getting serious about it looks like that, where you see that the whole country is geared around capturing this opportunity being offered by the fourth industrial revolution and its technologies and its modalities. Finally, when you come to, for example, extending our rare resources into rural areas, and so that's what the opportunity is, right? There've been countries doing telemedicine since the 1970s. Telemedicine literally means that I can, on a rotary telephone, I can talk to a doctor before I go in. And we've known since the 1970s that averts 75% of visits, right? So we can leverage what's there already to do so much better also in terms of things like access and universal health care. It doesn't need 5G to do that, but we act again as though we have to wait for that before we do these things. So a lot of it is just being really intentional about these things and then maximizing what we have. But most importantly, creating a model where everyone from the top leadership are incentivized to really get behind this in healthcare, because they know that their well-being also depends on getting this right.
You've got 15 seconds, Ernest. What's the one big thing you think we're going to see in AI in healthcare in the next 12 months? And the kicker here is we're going to invite you back in 12 months to see where we stand.
Oh, goodness gracious. AI in healthcare in the next 12 months. I do think we're going to see much more, how to put it, much more sort of autonomy. I mentioned the on the cutting edge, that is. On the cutting edge, I think we're going to literally see a situation where it will be clear that AI is, for example, better than a doctor in certain categories. And I think we're actually going to see some use cases, at least, where the AI is now, in essence, being allowed to lead. I think we're going to see more of that. But I think what we're going to see on the African continent in particular will be, I think, a lot more, how to put it, I think that we'll have a lot more engagement. I think we'll have countries, for example, with AI policies and things like that. But I think we will still not see a lot of scale up yet on the African continent, unfortunately. So it's a bit of a downer prediction for the African continent in terms of progress. I think in the advanced countries, we're going to see AI really going to the next level. In Africa, I think we'll still be very much we're developing our policies, et cetera, and we wouldn't yet have scaled up anything fully.
12 months, we'll see you back here, Ernest. If not before then, because I have 3 more pages of questions. But I think it's a great place to leave our discussion today. A huge thank you.
Thank you
It
so
was
much.
such a rich, thought-provoking conversation. And to our listeners, if you found today's discussion interesting, please follow us wherever you get your podcasts. The entire series is published on all the major platforms, and share this episode with your colleagues. You never know who might be inspired to innovate. If there's a topic or guest you'd love to hear on the show, head over to the MedEd Network, drop us a message on the contact form. It's due to be a chilly weekend, so from us here at the network, stay safe and stay sane. Cheers.
You've been listening to the Medical Education Network.